We will have a floral welcome from the Department of Neurology team to the esteemed guests and guys.
We are extremely proud that he is with us, and I would like you to give the bouquet to our chief guest. Mrs. Tanuja, just stand up. Tanuja is a double master's degree holder who came made of spices. Especially, you can take it off after a little while of wearing it. Yeah, so the next person who will. Thank you so much, Akshita. So,
Professor Harsha Halahalli to kindly invite to kindly share his thoughts about the current program and his insights with us.
Event Dean Professor Dr. Prakash, Professor Neil Robertson, and Mrs. Clare. First of all, I think we need to switch off. Extend a warm welcome to our guests, Professor Neil Robertson and Mrs. Clare Robertson. We are delighted to have you here on behalf of the university, on behalf of the Vice Chancellor and other dignitaries of the university. I welcome you also. Pandit has been literally running around for the last couple of weeks, very excited about receiving the Robertsons. She's really worked hard to put together this meticulous program, and she has kept us on our toes too. And I can see the reason for our excitement. The Center for Advanced Neurosciences Research, led by Dr. Lekha Pandit, and the Division of Clinical Neurosciences, led by Professor Robertson at the University of Cardiff, in multiple sclerosis and related disorders, CNS disorders. And both these centers here at NITE and at Cardiff are serving large populations of patients. They've been able to generate very useful and hard to combine epidemiological data. Both have successfully combined patient services with research, which is not always easy to do. And from what I understand, having listened to Dr. Lekha and interacted with them, the interests of these two groups, of these two centers, are similar but also complementary. From what I read, I understand that Professor Lekha's research is looking at developing novel diagnostic tools and susceptibility factors for MS-related disorders, while Professor Robertson's group is looking at prognostic markers, prognostic tools, and markers which help in appropriate therapeutic intervention. So there's this, complementary and dovetailing interests. And given these dovetailing interests, I'm sure that this visit by Professor Robertson and Mrs. Robertson will be a very productive and enriching experience for all the students and teachers and others who are involved with this work. Of course, along with Professor Robertson, we have as a bonus Mrs. Clare Robertson, interacting with our physiotherapy students and faculty, and being a neurophysiotherapist with immense experience. I'm sure that will also add a great value to our faculty and students here. The Center for Advanced Neurosciences Research is a rare special unit of the university. It is a model for successfully combining patient services with research. Dr. Lekha is an uncommon example. Dr. Lekha, who leads that center, is an uncommon example of a clinician who has combined research, a clinician scientist who has demonstrated that research and patient services can indeed go hand in hand. As a devoted clinician, much sought after clinician, she has in fact shown that research need not hinder or come in the way of clinical services, but in fact can enhance patient care when it's a well thought out and well executed research program. And I'm sure that Professor Robertson, who is also a similar successful clinician researcher, will inspire many of our faculty and researchers to follow in these footsteps. As a university, we need to integrate clinical training, academic research, and patient services. I'm sure Dr. Prakash and team will agree that as a university, unlike regular service institutions, we have this additional responsibilities of training and academic research. And I think we need to inculcate the spirit shown by our Center of Neurosciences Research here and Professor Robertson's unit in Cardiff as how this can be done successfully, how the apparently different aspects of patient services and research and training can in fact be brought together in mutually beneficial ways. I'm glad that as we celebrate the Silver Jubilee year of the medical school, Professor Robertson, for information, this is the 25th year of the medical school of the university. We are glad to host international experts like the two of you, with whom I'm sure that we can learn together and can collaborate and grow together. With that, I think we should move on to the primary reason why we are here today. I'm sure that all of you are eager to listen to Dr. Lekha and Professor Robertson deliver their talks. Let me thank our guests for being here with us today once again and welcome them once again. And I hope that this marks the beginning of a long-term relationship, collaboration, which will be mutually beneficial to all of us. Thank you. Thank you very much.
Thank you, Dr. Harsha, for your inspiring words. Same guests on the dais to take their designated seats, please. Professor of Neurology and Director of the Center for Advanced Neurology. She'll be giving a brief overview of patient management in resource-constrained settings.
What's happening in the real world, all are welcome to this small function. And you may wonder, why is the host jumping ahead of the the guest speaker to deliver? I think this is deliberate sabotage, maybe? Some misogynistic person is sitting in there. Yeah, so give a talk ahead of Professor Robertson. I wanted to kind of provide context to what he's going to be talking about, the problems of MS globally and the challenges faced by not just the developed world, but also the developing world, more so the developing world in terms of diagnosis and management of these conditions. So I just wanted to share with you the fact that we have had so much of issues in the last quarter century trying to give credibility to a disease that nobody understood among the medical community or in the lay public, for which treatments were not available, and the trials and tribulations of working as a neurologist treating diseases which I just wanted to give you what we have done using the example of our registry, which has got a very nice acronym, MANDIR, and this is our story. So you may ask, why tell us your sad story? We don't really need to know about it, but surely you need to, because there is a global increase in prevalence of autoimmune disorders worldwide. Even in countries where the prevalence has been studied meticulously, there is definitely over the decades a genuine increase. And it's not just because we have more MRIs and more neurologists in our part of the world. There has to be a genuine increase in the numbers of patients that we see. And that is also reflected in the number of patients I see in my practice. And also we should understand there's a significant skew in the ratio between women and men affected, predominantly affects women, and young girls, so much so that in the USA they say autoimmune disorders constitute one of the 10 most important causes of morbidity and death among women and young girl children. So that is the significance of this disease. And if you look at those who are skeptical, if you look at the overall prevalence of disease, that is for MS, 2 decades ago we didn't believe that we had MS. It was reluctantly reported of having a prevalence of less than 1 per 100,000. Now we know more indirect mapping of the global prevalence suggests that we have easily gone into at least the median prevalence of up to 20 to 30 per 100,000. If you look at the slide below, this is a reflection of the prevalence of SLE, systemic lupus erythematosus, which shares almost the same prevalence globally as does MS. And so you can imagine rheumatoid arthritis, Sjogren's syndrome, conditions that you name, recognize, have more or less a similar frequency and prevalence, and you can add up the cumulative number of autoimmune diseases that exist in our country of 1.4 billion people, and you will realize how significant the actual prevalence of autoimmune diseases is. And so we have shown that, and so also very, very good and large publications from the West, that autoimmune diseases coexist, and we have found the same. So I'm not surprised when I see a patient with autoimmune thyroiditis, and my friends who are sitting here, the endocrinologists, the skin specialists, will see psoriasis, vitiligo. My respiratory colleagues will see a variety of autoimmune atopic conditions coexisting with disease. And the very next following week, I'm seeing a patient who has a regional ileitis, Crohn's disease, recognized by a gastroenterologist specialist who also has MS. So that is to understand. Unfortunately, the impact of the disease is not felt because we all live in compartmentalized little bubbles. We seldom interact. My rheumatology friends and I have common cases that we treat. So it's very important to note that there is a huge impact of this disease on the community. So the skewed ratios worldwide, when we look at different diseases, which includes also India, you can see systemic diseases, multiple sclerosis, you name it, they all have a predominant female preponderance. And in our part of the world, that creates a great problem that that attitude towards children with the disease is more favorable towards the male of the family. And in terms of spending money lifelong on a patient's health, it's likely that the male of the family would get preference. So therefore, there are many ways we are disadvantaged as a consequence of this skew, and that we face during treatment decisions being made for these patients. So the clinical challenges are many. We have to show, when I started 25 years plus ago, my greatest problem was that trying to show that this is not some exotic disease seen in patients of people of European descent. And that was one of the biggest challenges, because people never took us seriously when we said that there are real cases that we see and that they are amenable to treatments. So we have to understand, in order to provide credibility for this disease in our part of the world, I understood that we need to show the burden of disease in our country. We had to understand if it's lesser prevalent, is it any way different from those seen among white populations. We have to find out how do you differentiate these demyelinating disorders, but because unlike the common thought, it's not a homogeneous disorder. There are very many autoimmune disorders which superficially mimic each other and lead to a huge burden in terms of diagnostic challenges. And then finally, how do you treat Indian patients who find imported medications unaffordable? So I like to think that we made a dent into all of these aspirations over the years. So in a single page, I would show you what I could do in 25 years. So we established the first population-based prevalence of the disease in India, and it's approximately at least 20 per 100,000. In a billion people, 1.4 billion, approximately it would be at least 150,000 patients with MS. You would have a similar number with SLE, rheumatoid arthritis, Sjogren's, you name it. So therefore, the cumulative presence of autoimmune disease in the community is definitely, this is a very modest estimation that I'm making. Is the disease different from that seen in white population. So we've done a lot of genetic and environmental association studies which are very much India specific and which shows, I'm sorry to interrupt, but I think there are very valuable members of the community who need to be seated, so we need to accommodate them. Yes. So he's the most important person, my radiologist. Without him, I have no MRIs. Yes, yeah. So we have developed diagnostic lifestyle-based assays and which we have patented, and we are able to provide at a fraction of the cost of the commercial and less sensitive assays. And then, of course, we have developed treatment algorithms using inexpensive off-label therapies and generics and biosimilars, and we have a very successfully running subsidized medicine program for immunosuppressants for my patients. So all this we could put together after many efforts over the years. So if you look at any picture of MS community on the Multiple Sclerosis International Federation website, you will see there are white patients, brown patients, white doctors, brown doctors, and there is even a turbaned person sitting in a wheelchair, just to show you the diversity and the fact that it's accepted that people who are non-white are prone and susceptible for these autoimmune disorders. So clinical challenges, I wanted to push my clinicians into understanding that patients will not come to us with a placard saying MS. I would have to necessarily sort out anybody who has a white matter disease will come to us. I'm grateful for that referral, but I'm trying to say is that we need to sort them out through sensible clinical evaluations, and we get variety of conditions, not just autoimmune. We can get vascular pathologies, amyloidosis, metastatic lymphomas, you name it. So when you sit in a general hospital, this tells us our wide referral also in a way, and also makes sure that our neurons are firing all the time to be able to differentiate these different conditions. So I'll put on some more commoner things. For example, we CNS vasculitis, our good old tuberculous myelitis, which will come and hit you when we least expect it to. And then, of course, this is the patient we saw 2 years ago, a patient who had contracted HIV during the mother's pregnancy, transplacental transmission, and came to us with one episode of optic neuritis seen by Puneet, whom you all know, who went to work in the Gulf, and turned out that it was HIV positive. So that, in a general hospital, there's a strength of our referral system. We get a variety of disease. So it's no easy joke. I'm not saying that you can investigate and drive that patient into poverty by doing all and every investigation. It is only sensible approach that will help you to sort out with minimum cost to the patient. When it comes to the actual white matter diseases, there are myriads of primary idiopathic autoimmune mediated disorders which closely resemble each other. So the ophthalmologist, the pediatrician are important gatekeepers for these disorders which manifest over time. They may be seeing the first or one of the many attacks that the patient may have had, but seldom would you consider asking about past histories, because for an optic neuritis person who comes to this general ophthalmologist, I'm not talking about the ophthalmologists and pediatricians who are sensitized to these conditions in our hospital, a virtue of our center, but the average ophthalmologist probably do a CT scan to exclude a pituitary tumor, and they would give a short course of oral steroids, and it's done. They never know in the past they ever had a myelitis, or the fact that this patient could ultimately end up having a very horrific disease for which the window of opportunity for good treatment is already gone. So therefore, we need to have powerful biomarkers to help us to differentiate, and I'm glad to say that 2 out of these 3 biomarkers we've developed on our own with governmental funding, and we offer it very subsidized. And oligoclonal bands, which are special proteins, we have the equipment to do that. All of it under our room, which reduces under the same roof, which reduces cost, and of course secondary costs we spoke about. Ultimately, you're left with a litany of diagnostic conditions which we have to carefully consider. In a specialist setup like mine, I have the ability to do that, but when it comes for the first time to an ophthalmologist, like I told you, or to the pediatrician, even to the neurosurgeon. Yesterday I showed Dr. Robertson a patient who had an extensive cervical laminectomy done in a hospital elsewhere in Karnataka because of the swollen acute cord lesion, which was mistaken to be a tumor. A young boy when he was just 5 years old. And of course, you can have the gastroenterologist having patients with intractable hiccups, vomiting, for which ultimately they will probably consider us to exclude central causes, which may be one of the first attacks of very aggressive demyelinating disease. So ultimately, delayed diagnosis, delayed treatment can lead to irreversible disability because the window of opportunity is very early and treatment should be very aggressive. So that's how the Bangalore Demyelinating Disease Registry came. I will quicken the story. So we started in 2010. We started as a small community-based registry based on our original Indian Council of Medical Research funded project. And then we had such a good networking with referring doctors, which continues to this day, from select areas in coastal Karnataka and beyond, that it extended into adjoining cities and states. And now we are basically a hospital-based registry, which is a referral center for demyelinating disorders in South India and beyond. We have patients from the north and northeast also, and we have patients from Nepal, Bangladesh, Sri Lanka, and also our expats come to us from the Gulf. Sometimes by referral, mostly by patient to patient, and sometimes through looking at us from the website and so on and so forth. So in the registry, we have now currently 1,289 patients on regular follow-up. There's a wide variety of disorders. Of course, MS stands out top, but the rest of them together make up almost the same numbers as MS. So it's extremely tricky having to make a diagnosis because each of them have a different pathophysiology, different modality of treatment, and different expectancies from those treatments. And also it's important to know that 15% of our patients have pediatric onset demyelinating disorders, something pediatricians should understand, especially this particular antibody-mediated disease is very, very common in children. So we have children as young as 2 and 4 who have come to us after having recurrent attacks. Somebody should be drinking water, I think. Yeah. Decision, the various challenges that we face, as all of us know, patients come to us with limited or no medical records, patients cross other state lines for treatment, they have exhausted other avenues before reaching a teaching facility, and so forth. Therefore, investigations have to be extremely streamlined and specific and cost effective. So we have developed a wonderful protocol which we shared with Dr. Neely yesterday. Ragaraja and I and Sharik Mustafa, my wonderful colleague of yesteryear, we all sat together and put together a good demyelination protocol which is cost effective and very comprehensive for looking at various aspects of the brain, which is different from the routine protocols done for other things. And we have protocol-based OCTs and visual evoked potentials which we do, which we repeat, and it's a very good non-invasive method of long-term follow-up of patients. We have CSF testing. All of our anesthesia colleagues will realize we request for more than 10 ml large volume. You cannot go back and puncture a patient again. And these are put in biorepositories, stored for eternity, and used for a variety of testing. Oligonucleotide bands we do in our own setup. And then we have our in-house assays which we talked about. So we also store all our investigations. The PG postgraduates who are posted with us have stringent instructions on how to write my discharge summaries, and dreadful outcomes happen to those who fall out of line. So then we have telephonic follow-ups as well with our patients, apart from the face-to-face interactions, all of which Akshata and her colleagues take care of. So I just wanted to see the last column briefly. I just want to explain to you why do we keep our investigations cheap. That's because we have equipments given to us through generous donations of many people, including Professor Dr. Narayan Shetty, who gave us more than 4.5 crores of these close to 10 years ago, and we were able to buy so much of equipments which translated into good use for patients. Then we have other equipments given to us through various fundings from governmental setups, and so therefore we have a very well-contained, small, self-sufficient investigative system which allows us to keep the cost tremendously at a low rate, all because of the good support from Niti University, which doesn't insist that we should put excessive margin on any of these tests. So they are a fraction of the actual cost of the tests that are done elsewhere, and that makes it so much more easier for these patients to come to us and get treated. So we have great challenges in the treatment of diseases, and I was envying all the different options that could have been there for a given patient. And all the patients I showed Dr. Robertson, he was telling me if it was in Wales, and it was like my eyes, my mouth with water, and I said, oh my God, if my patient was there. The wheelchair-bound ones have come asking, is there anything more that can be done? And if he lived in a different country with a different medical setup, he would have been intervened with much earlier, and he may not have ended up in that state. So the problem is, in our country, there's out-of-pocket spending, no insurance cover, high efficacy drugs are unavailable or extremely expensive. We have a new state-of-the-art MS drug available which costs 6 lakhs per infusion every 6 months. So they asked me to inaugurate it, and they said, what is your final word? I said, your drug will go the same way all your other drugs went. Nobody's going to be able to afford it. And that's something which is not understood. So we have to wait for the patent period to run out, and we have to make our generics for our patients. That's the only way I think we can manage to overcome these shortcomings. But we are not alone. Most of the countries, low middle income countries, more than 50% have no access to any of these high efficacy drugs. When it comes to low income countries, 100%. There is no access to any medications in these countries, which includes parts of Africa, Southeast Asia, and so on. So how can I drive down cost of therapy? Because all our aim is to attract enough patients, make sure a large number of patients fall under treatment cover. So being the Malayali I am, I said, okay, let's look at the competition that is there for us. So we pick companies which show interest against each other and say, oh, he's giving me at 6 rupees, what are you giving me at? So that kind of hassling, and finally we worked out a system in which we managed to get quite a number of drugs introduced into the pharmacy. The drug gets sold from the pharmacy at significant cost reduction. And some of these examples are there, both the off-label medications and the generics. I just want to bring up the rituximab, which is a monoclonal, is a B-cell depleter, which is used for a variety of conditions, which we use as an off-label therapy for rituximab. And you can see the tremendous difference in cost when we buy it directly from the stockist vis-a-vis buying it across the counter. So that's a success story. And they are happy with what we want to price it at, because by the 3rd month, their year's quota is over from the number of patients that we provide. We used to have 3 to 4 infusions per month. We have at least 20 to 30 infusions per month, showing the number of patients who are willing to buy this. And these kind of systems work well in India because the patient just has to wait up till the 6 months to make the money for the next infusion. And we have other protocols now being looked at, which is showing us that maybe we can even relax the intervals longer, and we have some interesting work that's coming up. So we have off-label drugs, those drugs which are used for other conditions, which are used for MS, as well as on-label therapy with the original molecule or with the generic versions. Generic versions, the first question would be, are they effective? Do we have any head-to-head comparisons? We don't, but still we use them because of the fact that they're tremendously cheap compared to the imported molecules. Off-label therapy is used in more than 70% among patients in different parts of the world, so there's no shame to using it. But the problem is, how effective are they, and how effective are they going to be remaining in the long term? That's the only hassle. So subsidized management in patient care, people would ask, why do you keep on talking about subsidy? We also like our patients. We also give them samples. We also occasionally give them this or that. But these are patients who have a chronic illness which is there for their life. And when they fall ill, they can't just walk in. They need to have at least 2 or 3 bystanders with them. They will have other comorbidity conditions, steroid-induced diabetes, hypertension, you name it. So treatment will be expensive, however much you can reduce the cost. So that's the thing. The why question should be answered that way. So we have schemes that the university has provided us with. The MS Society support scheme, which has been there, which reduces the cost of investigations and a final discount of 30%. And we have a neurophysiology physiotherapy package for just 250 rupees per day. People come during the summer holidays when the children have holidays, and in Dasra, stay for a week for top-up physiotherapy when they have significant disability. And then we have rituximab infusion happening in the general ward. Some of you could see in 13th counter. We have everything set up, but it is not charged extra. The room doesn't get charged. So therefore, these are some of the things. Modified plasma exchange, Dr. Janardhan will know we will do it at a cost less than 50% of what is being charged outside. Just one final slide. There's a growing interest worldwide about treatment inequity and treatment practices among those people who live in much more high-income countries. So in 2021, there was a paper published in a multiple sclerosis journal talking about the ethical use of off-label therapies. They were finally willing to accept that you can give off-label therapies and it may not be exactly unethical. And I wrote at the editorial for that particular paper, of course, fiercely championing the reason why we should consider this as a mode of therapy. And then, of course, finally the WHO endorsed this and included some drugs into the essential medicine list. But however, in India, it has never translated into anything meaningful. And you need powerful lobbying at the center, which unfortunately I don't have. We have reached out to many colleagues, and finally, it is not really translated into any meaningful action. And hopefully, hope never should win, but hopefully something will happen in the near future. So the invitations we get to talk outside also have changed. They want to know about comorbidities among your patients, whether it's South Asian, Southeast Asian. There's a real genuine curiosity academically to understand how we manage them. I was called to speak a couple of weeks ago about global perspectives on MS, and the topics and the questions asked of me was how do we manage, how do you keep your costs down, how do you keep your patients on follow-up. These are questions and that never came to us. There was no real interest earlier on. And I met a bunch of lovely young people. The tall fellow in the foreground actually is from Karkala, but he's one of those people who didn't want to do MCQs, jump ship, eager to learn, eager to assimilate. The future neuroimmunologist will never come back. That's the sad part. So all of them met me and they were so thrilled that Indian neurology is getting the recognition it requires, but these bright minds unfortunately are unlikely to come back to us. But that's the state of how it is. So in summary, patient-centric, physician-driven effort by a very small team. All of them are here. Shema looks really nice with that greenery behind. Off-label therapies and subsidized care are at the very core. We have a very long follow-up, and we have remote monitoring for our patients, and there's enormous goodwill and support from the university that strengthens our efforts. And I believe that this can be a model used by anybody sitting in a teaching setup with all the infrastructure that is mandated by the NMC to provide quality of care for any chronic disorder, be it a common condition like diabetes or maybe be it something more complicated. So with this, I will stop, and thank you so much for your patient listening. So I think I'm going to introduce Professor Robertson next, and if there are any Q&As, we can have it addressed in the last 10 minutes or so. So it's my proud privilege to introduce Professor Robertson. He is currently the Professor of Neurology and Chair at Cardiff University. He is also the Honorary Consultant Neurologist at the University Hospitals of Wales and the Royal Glamorgan Hospitals. He is the President-elect of the Association of British Neurology. And he was educated earlier in London and also a specialist training in various parts, including the prestigious National Hospital, Queen Square. And then he did his MD in the very famous Addenbrooke's Hospital, which has many, many multiple sclerosis luminaries to their credit. And his research focuses basically on epidemiology and genetic epidemiology of neuroinflammatory CNS disorders to understand real-world data, disease biomarkers, and optimization of disease management. And that is what probably drove Dr. Robertson to seek me out, because I got an email from him in October of 2023 saying that I'm interested to come and see your place, and these are the reasons which I'm coming for, and that's how he has arranged this very, very important meeting with us. So he is the lead MS specialist that delivers services across southern Wales and also oversees general neurology services. And he's very interested in teaching. I could see the way he was interacting with Suhan and Dr. Lobo and delivery of undergraduate curriculum, neurology training at junior and senior fellowship programs. He's the editor of Journal of Clinical Neurology. He's extensively published. He's a member of very important decision-making bodies in the UK. So may I introduce Dr. Robertson to deliver his talk.
Which we expect. So before I go on, what I want to do is to tell you about two patients, and I want you to remember late 30s, and she was about the same age. And she had 2 young children, about the ages of 4 and 5, and she presented with a brainstem inflammatory lesion and a lot of T2 weighted lesions in her brain. She then went on to have about 10 relapses in the first year and died within 2 years. Okay, so that's the first important person to remember. And then the second one I want you to remember is a lady who I met actually while I was doing research in Cambridge. And she had an episode of optic neuritis when she was 18 years old. She'd had another episode of sensory disturbance aged about 14. And when I met her at the age of 81, she was a little bit upset because she'd recently given up jogging and swimming because she found it a little bit too much. So just remember those 2 patients, and those 2 patients, I think, give you some idea of the real challenges that we face going forward. So let us give you some idea about why I got involved in this. And it's interesting that as doctors we tend to problem solve. We want to problem solve for the patient in front of us. But what we perhaps understand less is how to problem solve for a community, for a region, for a country, or even globally. And we need to understand that the influences that allow us to do that are probably beyond our direct influence seeing people in clinics. And as such, we need to look for global organisations. And one of the global organisations, amongst a few others, that have had a really quite profound impact on multiple sclerosis is the MS International Federation. And that's a global network of all the 47 MS organisations that are currently seen. And their mission, as it were, is to strengthen and support by sharing expertise and resources, by championing and campaigning for increased awareness of MS. And I'll go on to say why I think that's so important. I mean, you've heard a little bit from Mecca about why that's important as well. To provide information for clinicians and for patients and for their carers, and to support international research into better treatments and ways of managing multiple sclerosis. So what is the Atlas of MS? So the Atlas of MS is a project within the MSIF which looks for global epidemiological data and is designed to produce a compendium of data which will provide information for political lobbying and pressure. And what it is a regional expert data collection. And I guess if we were to be hypercritical, that's its main problem, in the sense that it is not based on what we would consider a robust academic epidemiological studies, but information, sometimes with the backup of epidemiological studies, which are channeled through experts. We've used this data to produce epidemiological information, to produce information about clinical management, some of which again you've heard from Abbakka, and it continues to be updated every year. So every year we have this kind of this compendium of data which allows us to have a global view of MS. So you can look all this up. So there's an interactive website which gives epidemiological data for each country, and you can find the website and you can hover your pointer over the country of interest and you can find the epidemiological data relating to that country. So you've heard that there are 150,000 people, at least I should say, a minimum prevalence of 150,000 people with MS in India. But the compendium of data covers nearly 90% of the world's population. So it's a powerful data resource. It's incredibly well referenced in papers. In fact, I think it's actually my highest reference paper that I've written. And these are a few key highlights from the 3rd edition. So just for those of you to reiterate Lecker's point that if you think this is a small disease, this is a big disease. And so there are nearly 3 million people in the world with multiple sclerosis now. And the prevalence keeps on rising. And the reasons for that are complicated. People are living longer. There's probably earlier diagnosis. There is better access to technology, including MRI scans. But overall, the prevalence, the frequency of disease is still increasing considerably. And it's probably increasing quicker in lower and middle income countries than it is in the higher income countries, where it seems to have reached a relative peak. And also the epidemiology now focuses on incidence, so you need to know that every 5 minutes in the world somebody's diagnosed with multiple sclerosis, and again that's increasing. So what are the barriers going forward to the diagnosis of multiple sclerosis? And this was important. You may think that, we may think that may have ideas about why there are global barriers, but the biggest global barrier is that patients don't recognise symptoms, there's no understanding or knowledge of the disease. And also there's very little knowledge, this is globally, amongst doctors in terms of identifying symptoms that are relevant to multiple sclerosis. So it may be different in India, but for instance in the UK, if a 30-year-old woman turns up with a progressive hemiplegia over 3 days, statistically that's much more likely to be demyelinating disease than it is to be any other disease. And so we have developed a knowledge of it, but we need to spread that knowledge and make sure that people understand what the disease is, how it presents, and importantly that there are now things that we can do about it that are effective, but as we'll come on to later, they are critically time dependent. So where I work is in South Wales, and South Wales is a land of castles, steel and rugby. So the religion very much in Wales is rugby, this rather bizarre game where people beat each other up for 90 minutes on the pitch. And they have a cathedral, which I'll show you in a minute, for their religion. But Wales was very important in the Industrial Revolution. It was the centre of the Industrial Revolution in the UK, and at one stage it produced 2/3 of the steel in the world. And since that time we've rather ceded that priority to other things. And Wales is the bit that hangs off the end of the west coast of the UK, and its population is largely concentrated in the southeast around the two cities of Cardiff and Swansea, but it has a large rural population which we also have to look after as well. Cardiff has metamorphosed into a modern, thriving city, and this is the on the left picture is the University Hospital of Wales. It's a big hospital. It has around 1,500 beds, and I live right at the front in one of those tower blocks. But it has it's a huge facility which looks after almost the entire population. And on the right of that picture, as you can see, that's the cathedral to rugby, which is called the Millennium Stadium, which is very important to the Welsh, although they're not doing very well at the moment. So this is the parallel, really, with the Mangalore Registry, and why it's actually been interesting to look at something that does almost the exact same thing. Numbers and frequency of diseases are a little bit different, but the basis is the same. Like Abbakka, we've had to develop structures which can contain our research, and the structures are the Helen Durham Centre, which was named after the lady who died very quickly at a young age from multiple sclerosis. The Welsh Neuroscience Research Tissue Bank, which is a tissue bank which we collect a large number of samples, and we give samples out all over the UK and all over the world, which has really enhanced our collaborative ability. Something which I think is more difficult to do in India. And we've abandoned handwritten notes, and we have electronic medical records, which is really effective. And it's going to come. You are going to be using electronic medical records, and our overarching ethical framework is something called Snowdonia, which looks after all of the neuroinflammatory patients, or allows them access to research. And so 75% of our prevalent population are signed up for research. They're very research active, research enthusiastic individuals. And Snowdonia is a big mountain in the North of Wales. So we've had these data which started in 1985, actually before my time, by a rather famous neurologist called Professor Alistair Constant. And he did a couple of cross-sectional prevalence studies. But really since 1999, we've effectively and systematically collected every referral that has come to us. So we get about We do this through a central and regional clinic network. And we make about 100 to 150 new diagnoses a year emanating diseases of one type or another. We'll see probably twice that number to tell them they don't have that, but we make around 100 to 150 diagnoses a year. So we have a 97% case capture, so it's population-based. So again, slightly different, because people don't come from long distances to see us generally, apart from second opinions, but we know of all the patients who have MS and related disease in our catchment area of around 1.5 million. And we follow them all up, so we perform an annual assessment, which a clinical assessment on them. So it means that there are about 60,000 assessments in our kind of data bank looking at those individuals. And we keep them in this customized database system called Patient Care. And again, we have a parallel biobank. You can see it's very mirrored, this system, with about 120,000 samples in them. And we're interested, as you hear, in long-term outcomes and biomarkers. And our aim really was to develop this lifelong library of clinical information from disease onset to death. And so we collect patient-reported outcome, clinician-derived data. We have this rather bizarre scale in multiple sclerosis called EDSS, which is a bit difficult, lots of problems, but it is something that's embedded in our culture in MS. But also digitized MR scanning, genomics. So I think about 2,000 of our patients have whole genome screening data. All the demographics, which is linked to a national system, which is updated in real time, and the biological samples, which I've told you about. So again, this is slightly different. So our registry covers in total about 3.2 million, but is much more focused in the southeast. And we have about 4,500 patients in our registry. But only a small number of them will be NMO, by which I mean Morgad or APA4 and 4. But the vast majority will have multiple sclerosis. And you can see that we have the kind of normal split in terms of multiple sclerosis, with just less than half of relapsing disease and secondary progressive disease, and then about 11% of primary progressive disease, and a few percent of clinically isolated syndromes, which are becoming less and less as the diagnostic criteria are changing. We're able to make diagnosis much earlier based on sequential scans and lumbar puncture results. And over the years, as we've monitored this, and we can kind of produce epidemiological prevalence data in real time, you can see the numbers have almost doubled. So we've doubled the prevalence over about 30 years. And I wonder whether that's the same thing that you're going to see in India over time. And this is a kind of a pre-warning that it's going to become an important set of diseases for you, an even more important set of diseases. So one of the things that goes with this is clinical service delivery. And I'm going to shock you, I think, by telling you how much it costs for us to look after our MS patients. So every time I make a diagnosis of MS, the estimated cost in terms of lost revenue, taxes, income, social care, drugs, and medical services is about £1 million. So £1 million per patient. So every time I make a diagnosis, I commit state services or social services or drug services to the tune of about £1 million. And if you think that we have probably about 2,500 active patients at any time, you can see what a huge financial kind of burden this potentially is on the health service. But what a bigger financial burden would be if we didn't treat them and make them better, and we had to support patients with very high levels of disability. So, and just to give an example of the kind of team that we've developed, and this is just the clinical team, this is not the research team. So in fact, it's slightly out of date. We now have 7 MS specialist clinicians looking after our patients, including me, so I'm one of those. We've invested very heavily in MS specialist nurses, and I think it is amazing. I mean, you have the most fantastic specialist nurse here who seems to do everything, and I think absolutely amazing. And we're so that I think you should take that forward, because we've had to employ 8 of them to do the job that only one of them do here. So I think that's something for the future. But we also have a heavy involvement in research. We have research trainees that are involved in this subject, and they are the future. You are the future of medicine, and trying to get you involved in both in the clinical work and the research work, I think is absolutely key for the future. Like yourselves, we invest in physiotherapists, we have occupational therapists, and we have neuropsychologists. We have a data manager, which I think maybe is something to really consider, because the amount of data that you start producing gives you real strength and projection in terms of your ability to deliver care, but also to attract funding. And we also have a statistician attached to our unit. So separate to that, we have another 15 researchers, but that's the basic clinical work that we do. And some of those aspects are mandated. So just looping back to the idea of the MSIF, some of this is mandated because of the work done by organisations like the MSIF that say in a developed country you should have these facilities available to your patients. And I think that will continue to filter down. So since my time, which is 25 years as a consultant, but maybe 34 years working in the field, the situation has entirely changed. When I was a trainee working on the wards, around a third of the ward beds would be filled with patients with multiple sclerosis with severe disability, for which our treatment was purely symptomatic. So that's changed now so that I rarely ever admit patients to the ward, so our patients don't tend to come to the ward at all, and most of our patients that we see and monitor in clinic remain well. So that's a big sort of difference which is difficult to quantify, but certainly I think is real. And some of that has followed some great advances in the disease. So we now know much more about the genetic component of the disease, with 233 non-HLA associated genes, as well as the important HLA associated genes. We understand much more about the contribution of environmental factors, and we now understand the role of various subsets of T and B cells in mediating disease and inflammation, and some of that is now reflected in the way that we treat patients and the treatments that we select. Epidemiology and what we call big data, which is effectively real world data, so the data that Lepha and I collect and kind of archive has had a real impact in terms of changing treatment design, and I'm going to tell you a little bit about that in a minute. And we've had great new pathological insights in neuroinflammation and degeneration, particularly the role of B cells in cortical disease. We've started to develop more effective disease biomarkers, and I guess the lead one of that at the moment is neurofilament light chain. We now have some much more safe and tolerable, high efficacy medications. I realise that they're not available to you here yet, but they will be coming, and you will have to manage them, and you will have to design safety programs in order to avoid side effects. Having had a recent patient with PML on natalizumab who died, it's an important thing that you need to understand. And also the great impact of the refined McDonald diagnostic criteria. Ian McDonald was my supervisor for my higher degree, and has become a very famous name in neurology subsequently. So despite all these recent advances in understanding the pathophysiology of multiple sclerosis, the genetics of multiple sclerosis and the imaging, that's a connectome scan from a patient of ours in Cardiff, which can show individual fibre tracks. Our ability to predict outcome in an individual patient, just going back to those first two patients that I told you about, is very limited. But the problem is that we only have a short time to make that decision and come and treat them. And if we get it wrong, then it's much more likely they will get severe disability. So we do have some prognostic indicators, and this is, I guess, important for everybody in neurology and the neurology trainees. These are fairly standard things that we look for. So we look for what age is the patient, are they male, do they have motor onset, and is that motor onset, does it leave them with some fixed disability? Do they have multiple comorbidities, a high relapse rate? Do they have progressive disease? Is the onset in more than one place at the same time clinically? Do they recover from the first attack, or does it leave them with disability? Do they have bands? How many lesions do they have on their MR scan? And importantly, are they spinal? So all of those are really important. We all do that automatically, but we need to understand that their actual predictive value for an individual is quite small. And when you're deciding whether to put them on a robust, high-efficacy treatment, then you're basing your evidence on, should we say, things that are kind of more limited than you might imagine. The other important prognostic feature is the baseline MRI characteristics. And I think the most important thing here is to understand whether the patient has intraspinal lesions and whether any of them enhance, and also whether there are 9 or more T2 lesions in their brain. So that's one of the reasons why at baseline in all of our patients we'll scan their neuroaxis, because we're trying to develop sort of prognostic information. And you can see that if you've got no gap lesions and no spinal cord lesions, your estimated risk of developing a more severe progressive form of disability at 15 years is only 5.3%. But if you do have all of those, then it's pretty much half. So it's quite an important predictor. So I want you to kind of suspend belief really in your system of drugs. All drugs in the UK are free to the patients. So we can choose, as long as they're approved by NICE, which is the National Institute of Clinical Excellence, and the NHS, we can prescribe any drug that we like. So when we are considering who to give which drug to, and remember that there are now 16, I think maybe 17 drugs for active relapsing disease in multiple sclerosis and 1 in secondary progressive disease, then these are the sort of things that we think about. We think, what's the person like? Have they got a family to plan? Are they reliable? Are they going to take their medication at the end? Are they going to turn up? And do they have any other comorbidities? What's their compliance going to be like? How far do they have to travel? We need to think about the disease, and I've just sort of gone over why I think it's important to understand the basis of their disease, and then also the drug. So what's the effect, the mode of action of the drug? What are the likely side effects? And are they acceptable to the patient? And then for every patient like this, we'll have an MDT, we'll have a multidisciplinary team meeting where we'll go through all of these aspects, and we'll make some suggestions which will then be conveyed to the patient, but it is the patient's choice in the end. So that's the, maybe another message is when you're thinking about neuroinflammatory diseases, they're complicated. The drugs are now becoming complicated, and actually if only one person is making the decision, then sometimes you lose input from other important people who know as much or as more as you do about the disease. So all of our clinicians will sit down and provide input for all of the major disease-modifying treatment decisions we make. So this is the issue in multiple sclerosis, is that we've now got some pretty effective treatments. Okay, so there's no doubt that autologous hematopoietic stem cell transplantation is very effective in multiple sclerosis, but you can see the problem. The morbidity associated with it is significant, and there remains a certain mortality. So that's on one end of the scale, and on the other end of the scale, the drug interferon, which is still used, although in much lesser way, we think is pretty safe, but actually is pretty ineffective in treatment. So when you're trying to decide between Helen Durham and the 81-year-old lady who presented at the age of 18, you've got to make a judgment along that scheme as to how aggressive you think their disease is and what you think they would benefit from. So you could either start them on a high efficacy treatment, or you could start them on a low efficacy treatment, follow them through, monitor their disease, and then escalate them if required. So one of the things that's really helped in this regard is the contribution of big or real-world data, and that is information that's collected out of a phase 3 clinical trial. So it's great to have the support of a phase 3 clinical trial to get the drug licensed, but actually the practicality of putting it into your practice and treating patients over longer than 2 or 3 years, which is the phase 3 trial, is a bit more of a grey area. But registries have got together to combine to give some information on big data, and these are multiple national registries, and they tend to try and use, or we're trying to use, the same clinical tools, have the same outcomes, and increasingly there are standardized data and standardized outcome. So the really big, important data findings is understanding about disease behavior and disease outcomes. They were instrumental in changing diagnostic criteria for the McDonald 2017. They demonstrate how effective disease-modifying treatments are in real life, not in phase 3 trials, in real life. And they give you long-term data about safety and tolerability. And I think increasingly what we are moving to, particularly with drugs that are being repurposed, so you use some of those here. I mean, no drug company is going to do a clinical trial on mycophenolate in multiple sclerosis. On the other hand, real-world data would actually is now gaining traction in terms of persuading sort of bodies regulating bodies who make decisions around licensing. So I think that is something that is going to come increasingly. So pragmatic, registry-based, randomized controlled trials. And the other thing that the drug companies don't tell you is how long patients stay on drugs. So the idea is that this is a lifelong disease. So multiple sclerosis is a disease that you live with, not die from, usually. And the idea is that these patients need lifelong treatment. So this is some registry data from the UK from our unit, which looked at 7,000 or so patients and all the prescriptions related to those individuals. And what you can see is that all of the oral and injectable medications, apart from anatolizumab and some ocrelizumab, are in the bottom section. So the average time that the patients stay on either an interferon taxane or an oral medication is probably around 2 years. So they don't tell you that. But patients don't tend to like taking these medications. So it's a real trial. You have to keep them on. You have to keep them motivated and keep them involved. So there are some real differences. There's a group of drugs that is different, and those 2 drugs are what we call the induction therapies. So these are new therapies where we give them particularly for people with aggressive disease, and we give the drug once. We just give it once, and then we monitor them afterwards. And those patients stay on that medication in the sense that they don't change to another medication for longer than any other medical group. So it's likely, I think, that induction therapies, and I think the one that you will get first when it comes up license will be cladribine, will be a really important medication for you, because you can give the medication once, or they take it a few tablets or a few days, and then another course about a year later, and they require almost no monitoring and only an annual MR scan, and that can be done with medicine. So that's a really important thing, and there's no continuing maintenance costs, so they don't have to come up with the money every month for the new drug or every 6 months for the infusion, and they only need to be retreated if the disease reactivates. So that's an important thing. And then the other really kind of thing that's changed our practice entirely is this study which we first did in 2019 and then was followed up by MBASE. So MBASE is a kind of global registry study that looked to validate our data. And so what we did was that for about 5% of the individuals who we think have the worst disease, we thought had the worst disease, we gave them a high efficacy treatment right at the beginning, so within 2 years of their biological or their clinical onset of disease. So they were the worst, so they felt that those tables that I showed you where you had to try and decide who had the worst prognosis, these are the ones that ticked all the boxes that said this was the worst prognostic patients, so they were almost guaranteed to do the worst. So we gave 100 of those or so a high efficacy treatment within 2 years, very quickly as we could, and then we compared them to another group of patients who, on the information that we had, were much more benign, had a much lower relapse rate, didn't have very many MR lesions, and we thought we could put them onto an escalation paradigm, which means that we can start them on a low efficacy treatment, and then we can increase the treatment if there's evidence of disease breakthrough. And the outcome was that at 5 years, it was really clear that the ones that we treated early and aggressively had a much better outcome, even than the ones that we thought were benign. So this goes back to an issue that has been raised, I think it was about 2006, by my friend and colleague Alistair Coles, who wrote a paper about the window of therapeutic opportunity. So this is a real demonstration of the window of therapeutic opportunity. And this is being trialled now. It's called Deliver MS in a UK and North American trial, which hopefully will provide some answers in a randomised phase 3, phase 4 trial. So that will come out shortly. So as a result of that, and despite the anxieties and the natural tendency that neurologists have to be risk averse, which is true, that's the nature of us, we are now starting to shift all of our treatment to the right. So we're treating people much more aggressively, much more early, and it may be that we now think that actually treating people in the first year, the first 1 or 2 years is the most important thing you can do. You know, whether or not they stay on treatment after that might actually be much less important than treating people very early and very quick. And I think that has some important messages for autoimmune diseases in general. So I guess the question comes then, how do we go on improving long-term outcomes? And we've talked about early diagnosis. So the early diagnosis bit is the McDonald 2017 criteria, which now allows almost to diagnose or with a very small proportion of patients with the right clinical information in lung function within a few weeks of their presentation. So that's been done. We need to manage comorbidities, and I don't think we do that very well. I think one of the problems with having a rare disease is that every time a patient is told they've got a rare disease, they put every symptom and every problem down to that rare disease, and also they tend, and other clinicians who see them say that person with a rare disease, I'm not quite sure how to manage it and I don't know, and you know, that's back to the neurologist. But these patients get comorbidities in the same way that everybody else does, and we need to focus on those. I think in order to push that message of early high efficacy treatment, we now need to start being really honest with the patients in a way that we were slightly paternalistic maybe 20 years ago by saying, you know, you'll be all right and we'll look after you. And say, look, you've got this disease, these are the outcomes if you don't get treated. Because they have to make a decision, they have to be accepting of treatment, understanding what the future holds for us. So we sugarcoat it much less than we used to. I think the things that we're missing, and this is the big next bit, which we are working on, is clinically and biologically informative disease classification. So I suspect that there are patients, you know, we now know that what we called MS 30 years ago is clearly a heterogeneous group of diseases. But within that group, even now, I think there are people who are more B-cell active, who are more T-cell active, who have more complement activation. And we need to understand that balance, and we need to drive treatments to address that underlying biological markers. And we need to do that through prognostic markers as well, and we need to have effective biomarkers in disease monitoring. So why do we need this, and why is it so difficult in multiple sclerosis? Well, remember that we call it multiple sclerosis, but it's still a syndromic diagnosis. There's no test that we can do. It's not like diabetes. You can't take a blood test for glucose. You have to exclude every other diagnosis and make sure that it fits a particular pattern. But we all get it wrong, including me. It has this incredibly highly variable outcomes I explained to you with those 2 patients right at the beginning, and it's almost certainly got a high degree of biological heterogeneity. And to match that, we've now got a whole range of treatments that all work in different ways, all affect different parts of the immune system, different cells, or combination of the cells, and we need to match the individual patient much better to their mode of action. And we need to be able to address and identify the kind of more severe side effects. So there really are quite some bad ones now, you know, with progressive multifocal leukoencephalopathy, with Goodpasture's syndromes, with, you know, pulmonary bleeds, you know, liver failure. So it's becoming a more high stakes game, at least early on. So the main unmet need is individual prognosis, but also a response to treatment which aligns with underlying biology. And we want a biomarker that really works. And actually, you know, the brain is not that accessible. You know, if you ask a patient to have repeated lumbar punctures, it's not a popular decision. You know, it's not a thing that they want to do. MRI scans, well, they take a picture in time, but it's quite a performance to get patients into the hospital to have those scans done. And it would be much nicer to have a blood test that we could take that was repeatable and that was informative on an individual level. And I'm talking about an odds ratio around 10, I think, to make an individual type decision. So, you know, we already have some markers which we've gone into. The world is now exploring the issue of genes and prognosis. Some of you may have seen the papers recently in Nature or Science, which identified the first progressive gene for multiple sclerosis, so the first gene which was associated with outcome, and which is really exciting and biologically interesting. However, I think we tested that gene on all of our patients, and actually its individual prognostic value is not likely to be high. But it's something to watch. You know, there'll be more papers, and it may be that the future will be, you know, a genomic screen, a genomic chip, which looks at a series of genes, which tells you whether this patient has a poor prognosis or not. So these are the ones that we need. There are a whole range of biomarkers that are probably needed to manage MS effectively, and this probably could be said for any disease, but the ones that we're really missing are prognostic and predictive biomarkers. And we use them, so we can use brain volume, we can use a number of T2 and enhancing lesions, we use oligoclonal bands, which is effective, and we use, for instance, neutralizing antibodies in interferon, although people don't use interferon anymore, and we use JC virus titer, so the JC index for natalizumab, which you'll start using more because it's just about to come out of license and become generic. And so there has to be a system which offers JC index, so that's your likelihood of developing a predictor of developing PML. And the other thing that's become much more popular recently is the use of neurofilament. I think in pretty much all neurological diseases, although I think that MS has really spearheaded this. And again, it's effective, and you can see the differences between patients who are not on treatment on the right graph, so the highest level of NFL patients seen without treatment, and then the lowest levels of NFL, which is a marker of axonal damage, are seen in people on high efficacy treatment. And that is great, but I don't think, again, that it has an odds ratio in terms of predictive value of the kind of thing that we're looking for, and that will be a problem going forward. So what's going to happen over the next 10 years? You'll be glad to hear this is nearly over, Steve. So the first thing is that I think that there are going to be high efficacy treatments for progressive disease. I'm sorry to say I don't think you're going to see many of those for a while because they're going to come newly into license, and that's a problem for you, particularly in India. I think that we're going to see biomarker panels to guide prognosis and biology. It won't be only NFL, but it'll be a panel of biomarkers that give you some idea about individual prognosis. I think increasingly the world is moving towards early high efficacy treatment in an ideal situation. There will always be people who fall through the net and you only find 10 years later, and they will remain a clinical challenge for us, but the world is moving towards high efficacy early treatments. And I think there are some novel therapeutic targets, and the one that's trendy at the moment is activated microglia. And then the big step for us is not only to find things that stop the inflammatory process, but actually start to repair the damage that's been done and protect it against future damage. And those trials have already started. None of them have been positive yet, but it's a work in progress, and the big pharma is putting their mind towards neuroprotective and neurorestorative interventions. I think that the data that you have, Lekha, and you have in Mangalore, I think will feed through into these pragmatic real-world trials, and they will become quite influential, particularly in drugs that are not licensed specifically for multiple sclerosis. But don't give up there, because that, you have an ability to real leverage in terms of the governance and the controlling bodies who license these medications. And I think the other thing that we need to be able to do is to identify what we call progressive disease better. So those patients who stop relapsing, stop having an inflammatory component of disease, and start having a neurodegenerative treatment component, because those will require different treatments. And that was all I was going to say. So thank you for listening.
Thank you, Professor Neil Robertson, for your insightful presentation. Your expertise has truly enriched our understanding. Thank you.
Anybody in the audience? A brief one actually. The actual increase in number of patients over time, I'm sure even in England you would be able, I mean in the United Kingdom you can possibly look at the past prevalence vis-a-vis the present prevalence, and have you come up with any ideas beyond the fact that maybe you're diagnosing them more? Is it anything to do with more sanitation or more advancement? Because in India, I was telling you about this relationship between H. pylori, the hygiene hypothesis, and the emergence of autoimmune disorders. As you get more and more modern, your gut hygiene improves, so the protection you had against organisms like Helicobacter dies, and that may in turn be reflective of the increase.
Yeah. In fact, for a population, you have to have a kind of a virgin population, and then you have to follow them over a long period of time, which is difficult. The real standout thing, so one of the risk factors that's been identified maybe over the last 10 or 20 years is childhood obesity, and in the UK that's a problem. You know, we have a problem with childhood obesity, and that might be one of the driving factors. I think that I certainly agree with that. The idea that autoimmune diseases are increasing in general, and it may be that MS is effectively a reflection of a trait which is being more widely shared. But it's a very complicated thing to unwind only from prevalence data. So it's quite a difficult thing to do, but it's definitely, that those numbers, if those numbers had been obesity, we'd be saying we had an obesity epidemic. But because it's multiple sclerosis and it's a relatively rare disease, it hasn't quite got the press that other diseases have.
Now we have the honor of hearing from an esteemed dean, Professor Dr. P.S. Prakash.
Today's guest speaker, Professor Robertson, chief guest, Dr. Harsha, the organizers of today's event, Dr. Professor Lekha Pandit and her team, HOIs, heads of departments, my dear colleagues and students. When we were students, and also even now we as physicians teach that demyelinating disease is a rare disease of a tropical disease, but Dr. Lekha and her team has sensitized us enough to say that it's not an uncommon disease, though we can't call it a still common, not an uncommon disease, and possibly we should be looking out for these people, particularly the ophthalmologists, the pediatricians, and the physicians. Look out for look out for the signs and possibly early referral, and using the services of our neurological department. Interventions can possibly, as Professor Robertson said, an early intervention during the window period can have a better outcome. Otherwise, as all of us know, demyelinating disease itself is a very heterogeneous group of disease where multiple sclerosis is quite common. And the thing about this disease is exacerbations, remissions, and every exacerbation leaves its mark. Ultimately, it may not kill an individual immediately, but cripples. And over a period of time, not only the patient suffers because of the quality of life, the caregivers also gets affected. So we definitely, and look at the population difference. Young, very productive age group, and also the young caregivers. So we need to look. Right now, we have early therapeutic interventions designed. Of course, it should be much more cost effective. We need to have possibly biomarkers, early detection biomarkers, markers for exacerbations, early detection of exacerbations, so that we can keep the disease under remissions, have a few exacerbations, thereby we decrease the incidence of the disease, sorry, not the incidence, the going into crippling stage. Of course, the treatment or the management of multiple sclerosis is a multimodality specialty wherein ophthalmologists, neurologists, physiotherapy departments all needs to get in, and also the counselors, because whenever a disease has this type of manifestation, along patience is required on the part of the patient, the caregivers also. And of course, we know that it's autoimmune disease. Whenever there's an autoimmune disease, the three important factors that come into play is the genetic factor. Right now, of course, some HLA system is involved, but we don't have any definite answer for that yet. The environmental factor, possibly so many implications are done, definitive answers are yet to be formed. And immune system somehow going haywire. And once it starts initiating, what triggers of the recurrences, we just still don't know. The disease burden, particularly in a resource-constrained countries like ours, takes a heavy toll. And I'm sure Professor Legaman has her own come out with some novel diagnostic tool. And in this I see a future when the team from UK, that's Professor Robertson and Professor Lega, work together and take this, find a way of cheaper investigations and also therapeutic interventions. So I'm very proud to be associated here to preside over this function. I thank the organizers. I thank Dr. Robertson, Professor Robertson, and also his wife, Mrs. Robertson, for having come all the way from UK and spent your precious time with us, enlightening us, and I'm sure we all go a little more enlightened about this crippling disease. I thank once again Madam and her team for giving me the opportunity to preside over. Thank you one and all.
Thank you, sir. So as we move forward, it's time. Now I request our Dean to present the memento to Professor Robertson.